السلام عليكم ورحمة الله وبركاته. مساء الخير، أهلا وسهلا بكم جميعا. بارك الله فيكم على الحضور. إن شاء الله اليوم بنبدأ أول محاضرة من سلسلة محاضرات Interventional Cardiology Work Group حيلقيها الصديق العزيز الدكتور باسم الباروني. الدكتور باسم Associate Professor of Medicine وبروجرام دايركتور Interventional Cardiology Program في University of Reading. إن شاء الله اليوم دكتور باسم حيتكلم عن Introduction to Coronary Angiography. حيكون معنا في الإكسبرت بانل الدكتور محمد العيان من أمريكا، دكتور عبد الغني الساعدي من أمريكا، والدكتور عبد المنعم التومي للأسف اعتذر عنده حالة Inferior Stemi، لكن في الحمد لله الدكتور أسامة بهلي حيكون موجود معنا. يا ريت الكل يتأكد إن المايك متاعه على الميوت بوزيشن باش كنا نسمعوا المحاضرة بهدوء نستفيدوا. لو حد فيكم عنده أي سؤال يا ريت يكتب على الشات بوكس ويخليه نهاية المحاضرة، وإن شاء الله نسأل للدكتور باسم والإكسبرت بانل. مرة ثانية أهلا وسهلا بكم جميعا. دكتور باسم المايك از يورز، تفضل.
السلام عليكم ورحمة الله، شكرا على التقديم. زي ما قال الدكتور أيمن، هذه جزء من سلسلة المحاضرات focusing on coronary intervention. اليوم الفوكس حتكون على الانترودكشن، يعني التارجت audience هنا someone who's just newly graduated, just starting fellowship or starting cardiology. فإذا كانت too basic or boring معليش يصبروا معنا. الصورة هذا اللي على اليمين هذا مش يعني هذا من النت stole it off، يعني I have no idea who that is. القصة أو الانترودكشن نقول أنت واحد متخرج جديد كيف بادي امتياز، مشيت للدكتور بهليل قلت له أنا معك روتيشن تو في الكارديولوجي نبي نحضر معك في القسطرة اليوم، عندي قسطرة هل يمكن نحضر معك؟ قال الدكتور بهليل خلاص ما فيش مشكلة تفضل برا شوف المريض الأول وتعال لي. ماشي، انت تكرف رجليك للمريض الاول، مش عارف راسك من رجليك، ايش درت في روحك. الهدف من المحاضره هذه انك انت لما تمشي تشوف المريض الاول بتراجع تعرف شنو الاسئله اللي تسالهم وش المفروض تعرف على عمليه القسطره. هذه الobjectives of the talk: assessment of patients referred for coronary angiography, how is coronary angiography performed, and risks associated with the procedure. المحاضرة الجاية احنا نتكلم على الكوروني اناتومي والانجلز والفيوز to do a diagnostic angiogram. That won't be the focus for today. شنو هو كاف؟ What is كاف؟ نقولوا كلمة كاف اختصار لكوروني catheterization وبالعربي قسطرة. coronary angiography اللي هي بالفلاقي القسطرة التشخيصية، الهدف منها identifying coronary anatomy and disease with the view to decide on management. يعني عبارة عن diagnostic test. الأول management involved putting in a stent، هذا يقولوا percutaneous coronary intervention or PCI. وكان medical management أو referral to surgery هذا موضوع ثاني. يعني في الcath lab we do other procedures as well: right heart cath, RV biopsies, mechanical supports, structural procedures. في سلسلة محاضرات دكتور محمد الطريني هيتكلم على التابي والmitral valve clips. Depending on where you practice, مرات الcath lab is where pericardial stentesis is done, or transvenous lines, transvenous spacers. بس for the most part يعني التخصص باطنة القلب التداخلي interventional cardiologist the focus is on coronary angiography and percutaneous intervention. فانت ماشي بتشوف المريض، what is the first step؟ شنو الحاجه اللي بتقررها في الاول او تفهمها من الاول؟ علاش المريض تم تحويله للقسطره؟ من اللي حوله؟ بالنسبه in my practice حوالي 90% في المرضى اللي نديرهم في قسطره اول مره نشوفهم هو في يوم البروسيجر، محوله جنرال كارديولوجيست محوله للكاث لاب ومدير له تحاليله والورك اب وحجز على الليست بتاعي. طبعا يختلف من مكان لمكان. first of all need to know هل البيشنت جاي inpatient or outpatient، وشنو الكلينيكال indication for the cath. يمكن تقسيم ال reasons for coronary angiography إذا two or three streams. Acute coronary syndrome, البيشنت جاي ب acute events. Usually these patients will be inpatients. ممكن referred because of chronic coronary syndrome عنده اللي هو stable angina. وفي other indications: pre-valvular surgery or reduced ejection fraction. يعني الدكتور الديو مثلا جراحة قلب عندها مريض بميترال ستينوسيس or aortic stenosis يبي يدير له عملية، قبل يقدر يدير العملية لازم يعرف شنو الكوروني اناتومي، إذا كان في any lesions that affects the surgical prognosis، وحيحتاج يدير له bypass at the same time when he's doing the valvular surgery. الدكتور ايمن في العياده بتاعه عنده مريض لقوه عنده heart failure وعنده reduced ejection fraction. One of the differentials for heart failure with reduced ejection fraction is ischemic cardiomyopathy. فيحتاج المريض ان يدير له قسطره باش يعرفوا هل فيه انسدادات ولا decide on how to treat them. الأكيوت coronary syndrome في محاضرة في السلسلة بتاعها focusing on this, فهذا just quick introduction. لو عندك atherosclerosis, plaque forming inside the coronary vessel, if it becomes large where it's impeding blood flow, patient might present with stable angina. However, if that plaque ruptures or erodes, acute thrombus clot can form over it, leading to an acute narrowing in the lumen of the vessel or acute occlusion of the vessel. So if it's a narrowing, but there's still some flow, usually presents with unstable angina, or if the biomarkers are positive, non-STEMI. If there's an acute occlusion, the presentation would be a STEMI, ST elevation myocardial infarction. This is a patient presenting with acute chest pain, severe chest pain, and this is the EKG. زي ما تشوفوا فيه acute ST elevation, keep calm, don't freak out. This patient needs to go to the cath lab right away. حسب where do you practice يعني بالنسبة للpractice متاعنا, these patients we treat with primary PCI, we take them straight to the cath lab. If they're far away, then you need to thrombolize them. But that artery is occluded and needs to be opened ASAP to reduce to improve the patient's prognosis and reduce the amount of damage. So this is the angiogram of a patient with an acute anterior STEMI. هذا القسطرة الcatheter is sitting in the left main, injecting dye. If you see here, there's a vessel that's abruptly occluded. يعني شكلها زي amputated knee there. That's the LED. It's missing. It's blocked with clot. And this angle, this is the same vessel, same catheter. غيرنا الانجل متاع الكاميرا. There should be an LED coming down here. That's missing. So the patient would get primary PCI. And this is after ballooning and stenting. You can see now there's nice flow down the LED, and the patient's symptoms resolved, the ST segment resolved. So this is the stent is right here, and this is the LED that was missing in the previous angle. Now there's good flow down there. This is a thrombectomy catheter, just for demonstration. And remember, the artery is blocked with clot. We can suck out that clot, strain it, and these are the clots that was causing the heart attack, so we can actually suck them out in some cases. Opposed to a patient with a non-STEMI, where there is the acute narrowing of the vessel. You can see in the proximal LED here, there's a really tight lesion. However, the big difference in this lesion compared to the previous one is that there's actual flow down the LED. So this patient probably had transient chest pain, but didn't have ST elevation and needs to come to the cath lab within the next day or two, but doesn't have to be done right away unless there's acute symptoms. Stable angina, patients with exertional chest pain that's resolved with rest or with nitro, that is chronic, hasn't been progressively getting worse. These patients are frequently referred for coronary angiography. It is not necessary. Not all of these patients need to come for cath, as the results of the ischemia trial showed. إذا كنت حضرت المحاضرة متاعي الأسبوع اللي فات. بس يعني it's still common practice, especially since you need to rule out left main. Okay. So you now know why the patient was referred for cath. درت الأسسمنت عرفت علاش the patient referred for cath. The next step is to review what other investigations has been done. If it's an inpatient, what did the EKG show? You want to look at it. What are the cardiac biomarkers? And has there been any ejection fraction assessment? Has the patient had an echocardiogram? If it's an outpatient, has there been any previous non-invasive stress tests, stress EKGs, nuclear stress test, or stress echo? And what were the results? And what is the creatinine? I mean, you should review all the blood work, but in the cath, one of the most important blood works that we need to know is the creatinine. Okay, so you know why the patient was referred for cath. Now you know what investigations were done. Next step is, the third step is to review the past history. If the patient had any prior events, so any history of cardiac events, that's easy. But if the patient has had any previous interventions, that's important to know. They've had previous PCIs. When were they done? Which vessel was stented? What were the stents that were put in? If they had bypass surgery, when was the surgery done? Has they had any angiograms since then? And what were where were the grafts? If there was a prior angiogram, what were the findings, prior cardiac events, and also what are the risk factors? Importantly, diabetes, as it has a big impact on our decisions for revascularization. Smoking, hypertension, and dyslipidemia are also important risk factors as well. And if the patient is a smoker, this might be a good chance to advocate or advise the patient about smoking cessation. So now you know what the patient is referred for. You know what the tests are that he's had before. You know if they've had any past cardiac history. Now this next step is to decide on how to do the procedure. Okay. First question: what access are you going to use? Okay. So arterial access. This an angiogram is done through the arteries, not through the veins. The most common access points used are either femoral or radial. There are other less commonly used ones: brachial, ulnar, distal radial is making fancy, but let's just focus on these two. So the radial artery, when بتحس في الpulse usually, lateral side of the lower arm, goes up, becomes the brachial artery, axillary artery, subclavian artery, and then inserts through the brachiocephalic trunk into the ascending aorta. So direct connection to the heart. Femoral artery, the groin area, becomes the iliac artery, and then abdominal aorta, and then descending thoracic aorta, ascending aorta, and then connection to the heart. In this day and age, I think the majority of the angiograms, especially diagnostic angiograms, are done by the radial approach. That's at least in my practice. But I still do about 10 to 15% femoral. Who are the patients that I would go femoral? If they've had prior CABG, I personally still go femoral because, you know, especially if I don't know what the grafts are or there's no prior results, it makes it much easier. You can do patients with prior CABG using a left radial approach to get to the lima, but in general, I usually would go femoral for prior CABG. If the patient had a previously documented difficult radial access, so someone had an angiogram before, had lots of spasm, radial loops, or subclavian challenges, then I'd probably just go femoral. If the patient's coming for a planned complex PCI, either CTO or planned complex PCI, you get more support. You can use bigger sheaths and guides. Someone who's in a highly skilled vocation, يعني واحد يخدم بيده صنع حرفة, you know, when you go radial, there's a very small risk of affecting the hand motion, especially for someone who's, for example, a musician, etc. So sometimes that's a lower indication to go femoral. Personally, I do not do the Allen's test. I don't check it. I think that practice is pretty remote, but you know, I'll hear what the expert panel have to say. So you decided what the access was. Let's say patient mandash prior bypass surgery, you want to go radial. Then you have to decide on the sheath size. So the sheath is the piece of plastic that we leave in the artery to introduce our wires and catheters, okay? And we use the French system. So we describe the size in French. What is French? You know, 6 French, 5 French, or 7 French. 1 French is equivalent to 0.3 millimeters. So a 6 French catheter has an inner diameter of 2 millimeters. Generally, I usually use a 6 French system for the majority of my cases, diagnostics or PCI. Some places and some operators would use 5 French for that part, at least for the diagnostic part. And then if you need more support or more aggressive results or more complex procedures, you might need 7 or 8 French. Now, اللون الأخضر هذا اللي فوق, this is مش مدار عبط, this is universal. اللون الأخضر, the green color, means 6 French. So any catheter sheath that has green on it means it's a 6 French system, 6 French sheath. Orange, 7 French. Use this for complex PCI. Blue, 8 French. Not very commonly used, but occasionally we might need 8 French for really complex CTO procedures. It gives us a lot of options. The gray color is the 5 French system. Red is 4 French. وهكذا. كل French size عندها الcolor الخاص به. So we decided to go radial. Getting access, you use a Seldinger technique. After you do local anesthetic, you take a needle, you feel for the artery, زي ما بتدير في arterial line or video قفنا شوية. Okay, when you hit an artery, there's bleed back. This is not a vein. There's usually brisk bleed back, and then you feed this wire. And some resistance there, so you adjust the needle position, and then the wire now is inside the artery. زي سكة حديد, the railway, you can put the sheath over it into the artery. Sorry, that's not there. So the dilator, this piece from top, and the wire will come out, and it will left with the plastic tube inside the artery to deliver the wires and sheaths. And then you need to decide which catheter that you're going to use. Okay, there are lots and lots of different shapes of catheters. You do not need to know all of them. For any diagnostic procedure, you have a left coronary artery, left main, and the right coronary artery that you need to engage. So you need to choose two. I think majority of the operators, most operators will use the Judkins catheters, the Judkins left and the Judkins right. This is a picture of Dr. Judkins holding up his catheters right and left, and along with the pigtail catheter. هذا طولهم around 100 centimeters. So there's 100 centimeters long. So you get them all the way to the coronary artery, and there's a part of it sticking out that you can hook up to your system, inject the contrast through to take your diagnostic angiograms. So Judkins left. If you go femoral, usually it'll just fall into the left main artery. Okay. Now there are different sizes. JL35, Judkins left 4, Judkins left 5. What do those numbers mean? So if you look at the catheter here, there are two curves. There is the primary curve down here and the secondary curve down here. The distance between those curves, this part of the catheter is the length. So a Judkins 4 is about 4 centimeters length between the primary and secondary. Judkins 5 is longer, Judkins 3 is shorter. So Judkins left 3 is shorter. For the most part, I usually ask for a Judkins left 3.5 if I'm going radial, and a Judkins left 4, JL4, if I'm going femoral, okay? If the catheter is too big, in this picture here, it'll get stuck in the lower cusp and will not engage the left main. So if you see your catheter getting stuck there, take a smaller Judkins system. This might be the case if you're doing an angiogram on a smaller, older woman. Usually the aortic root is a bit smaller. On the other hand, say Dr. Dayoub has referred a patient for angiogram who has an ascending aortic aneurysm. So before he can operate, he needs a diagnostic angiogram. An ascending aortic aneurysm means that the ascending aorta is quite enlarged, and if you take a regular size Judkins, it'll usually collapse on itself or bends, and it will be above the left main. So if you see a patient referred because of that, usually I would take a Judkins 5 or even 6 to be able to reach the left main. So this is the Judkins left catheter to engage the left main. The Judkins right, I usually just take a JR4. The same thing applies for the distance, but I've never used a JR3 or JR5. If I can't engage with this catheter, then I'll take a different shape. Engaging the RCA with the Judkins right needs a little bit more skill. So while engaging the left is usually easier, getting into the right needs a little bit of torquing and adjusting, and there's a bit of a learning curve to it. Okay, so this is the catheter table. This is what it looks like. Patient will lie on the table here, have the C-arm. The X-ray comes from below, and there's a camera above. The table can be moved, the angles of the camera can be changed, and the operator can see in front of him here on the screen what he's doing. Usually you have a hemodynamic tracing with the EKG and the blood pressure, and then if there's something else that you're doing there. Okay, so the patient is lying on the table, X-ray is coming from below, the image intensifier is above him, and we can change the angles to take the pictures in different of the coronaries in different angles. I will detail this a bit more in next time, but just to summarize, this is what a left injection into the AP cranial looks like. This patient has an ICD as well in front of us. But you can see here now the LED is coming down in front of us. That's because it's a cranial view. In a caudal view, the left main and circumflex and proximal LED are apparent. The RCA basically looks like the letter C. Letter C there. This is with the Judkins right catheter. Okay, so you engage the coronaries, you take your pictures, and then you also have to decide if you're going to use a pigtail. So pigtail catheter is what we use for LV angiograms. So if a patient's had an echo, has an LV assessment, you probably don't need to do this, but if you're not sure, there's some certain indications, then we do an LV angiogram. So you need to cross the aortic valve with the pigtail and then inject dye, a larger amount, usually 35 to 40 cc's, and you get an outline of the left ventricle. And you can see if there's any wall motion abnormalities or structural abnormalities. We can also use this to get a tracing of the left ventricular and diastolic pressure. So the left ventricular pressure is what we're measuring here, this big curve here. There's two curves here, left ventricle and the left atrium. So we see the left ventricle systole all the way to diastole, and then there's sudden decline here. Then diastolic phase, and then systole again. And this is the tracing that we'd usually get compared to the usual aortic pressure. So the pressure right before systole is the left ventricular and diastolic pressure, and is usually quite elevated in patients with heart failure. Now this is an abnormal tracing. We also have left atrial tracing, so simultaneous tracings. I won't tell you what the diagnosis is right now, but as part of the series, we do have one lecture on invasive hemodynamic assessments of valves, etc. So some of you might have recognized what the pathology here. I'll put this back at the end for discussion. Okay, so this is another LV angiogram. The left ventricle looks normal, but is there anything else that's abnormal? This is kind of a show and tell. Spot diagnosis. I guess I won't open this up to questions yet, but I will point to you that there is a flap in the ascending aorta. That's a dissection plane. So this patient presented with an inferior Stemi, and the operator had a lot of difficulty engaging the right coronary artery, did an LV angiogram, and diagnosed the patient with type A aortic dissection. So this is and that was blocking off the right coronary artery. That's why there was ST elevation. So this is a medical emergency. You're gonna call your cardiac surgeon right away. Okay. So now you've done your diagnostics, you've taken the pictures, you see what's going on, then you need to achieve hemostasis. If you're going radial, there's a lot of different devices. The most commonly used, at least in our center, is the TR band. Basically, it's a bracelet that uses air to compress the access site. So you put it on, you pull the catheter out, you inflate air through this syringe, and it'll block flow. If you've gone femoral, then the simplest and the cheapest way to achieve hemostasis is to pull the sheath out and then hold the groin. You know, if you're doing 5, 6, 7, 8 cases a day, there are specialized closure devices that you could use to seal off the puncture. Commonly used ones are AngioSeal and the ProGlide system here, the PerClose. Okay. So remember, you're still assessing the patient. So you know what the patient was referred for. You know what his investigations he's had so far. You know what his past cardiac history is. You've made a decision about how you're going to make the procedure. So now you have to obtain consent from the patient. So informed consent, there's a few steps on that. The three major ones is to first explain why you are doing the procedure, how the procedure is done, and then you have to explain risk of procedure. Okay, mafish a procedure that is risk-free. There's always the risk of complications, no matter how good you are. There's always a risk. So what are the risks of coronary angiography? We can divide them into three. There's vascular complications, contrast-related, and radiation exposure. The vascular complications include the ischemic events, causing a myocardial infarction, causing a stroke, causing the need for emergency bypass surgery, or even death, okay? While I was preparing for this, I did a quick literature search. The most recent paper I found was this from 2019, looking from the Mayo Clinic at the risk of their complications. And they found the risk of ischemic complications were less than 1 in 1,000. So really low risk, but not zero. This is a complication I had myself. So this is a diagnostic patient, had atypical chest discomfort, but with recurrent presentation, so it's referred for angiography. So engaging the RCA, that is going down, okay, no problem. But if you notice here, suddenly there's a second layer or second dissection plane that's formed. It's not very obvious for a reason, because as soon as I saw it, I stopped injecting and stopped taking more pictures. This is an iatrogenic coronary dissection. If this happens, first step, stop injecting. If you're not sure that there's a dissection, if you just did another cine without injecting, the dye from the previous injection will hang up there and will give you a diagnosis. If you keep on injecting, you'll cause this dissection to expand, leading to the vessel occluding. So stop injecting. And then the next step is to take a guide and get a wire down the vessel ASAP to secure it, because you're going to have to stent this to prevent it from expanding. So this is the same artery. Now I've got a wire down there, a coronary wire. So I've secured the vessel. So now I'm okay injecting a little bit. And you can see here that there's a lot of dye staining. That's from the dissection plane. So I had to put a stent there to secure it. And this was the final results there with the stent. So, no major complications here, but could have led to a major dissection, et cetera. And we do see that from time to time. Now, access complications, vascular complications, bleeding. These are most commonly associated with femoral access, which is why I prefer going radial. The access point, where do you want to stick the femoral artery for access, should be below the inguinal ligament. And for anatomy, inguinal ligament starts in the superior anterior iliac spine and then connects to the symphysis pubis. This is the point where the superficial iliac artery becomes the common femoral artery. So this is the area where you want to stick the needle. You want it to be above the bifurcation of the femoral artery. So here it becomes the superficial femoral artery and the femoral profundus artery. If you're too high, if your stick is too high, you risk retroperitoneal bleeds, which can be fatal. If you're too low, you risk causing pseudoaneurysms, which can be challenging to treat as well. On fluoroscopy, the marker for the inguinal ligament is the inferior epigastric artery. This inferior epigastric artery makes a loop around the inguinal ligament. So if you're above that, you know that you're too high. And of course, you can see the bifurcation. The femoral head is a good landing zone. If you try and hit the artery between the femoral head, then you should be, in most cases, good. So a lot of operators will use fluoroscopy to see the femoral head before they puncture. This here is a very good puncture. You can see that it's above the bifurcation and below the inferior epigastric artery. Sorry, inferior gastric artery. This is a low puncture. It is into the bifurcation. So in this case, the risk of a pseudoaneurysm is high. This stick here is way too high. This is into the iliac artery. This risk of retroperitoneal bleed is pretty high here. Now, radial complications can still happen as well. Major bleeding can happen in the arm. This poor lady was quite bruised after her procedure. This happens, and very, very rarely compartment syndrome can happen. It's almost like a case report, although we've seen it a couple of times. Radial artery bleeds can happen as well. That should be secured. Contrast-induced nephropathy is also one of the complications we worry about, especially in patients who have chronic kidney disease. So if they have renal impairment, the risk of contrast-induced nephropathy goes up. If they have diabetes or heart failure, the risk of contrast-induced nephropathy goes up. So if someone is referred for an angiogram and they have renal impairment, it is not essential. It's not a contraindication. We can still do the angiogram, but we have to be, first of all, really clear that the angiogram is necessary, that we inform the patient of the risk of contrast-induced nephropathy, and we use the least amount contrast necessary. I've done diagnostic angiograms with less than 15 cc's of contrast. I've done planned PCIs with 5 cc's of contrast. There are ways to do that. There are, you don't need to use 100 cc's of contrast for every PCI. Radiation is a very important component. The risk is not just to the patient, but to the operator as well. In fact, it's probably more to the operator than the patient because we do this every day, frequently. So the risk is shared. ALARA it means using the least amount reasonably achievable. The risk to the patient is twofold. There is the risk of acute skin burn or injury, radiation dermatitis. This happens if you've used a lot of radiation. So really long, complex PCIs, especially if it was in an older system, if in an obese patient as the radiation exposure is higher. If you hit the 4 to 5 gray, which is really high, the risk of skin dermatitis can happen, and that's the acute thing we worry about. So if you have someone who did a complex PCI and your radiation exposure is high, it's important to inform the patient of this risk, and that if they have it, don't let anyone do a skin biopsy from it, because if you do a skin biopsy, it's very difficult for it to heal. So it's important to avoid. There are important safety techniques to reduce the radiation. So this operator here, that again, I stole the picture from the internet, is using the radiation shield here to protect him. Notice that he has the table high, away from the radiation source, and the image intensifier or camera as low as possible. These are all important steps to reduce the radiation. You take the pictures that you need and not more than that. Okay, so don't keep your foot on the pedal for too long. And if you can get away with fluoroscopy for fluorosave for a lot of images, might be achievable as well. You can also reduce your frame rates of the pictures to reduce your radiation. The operator under his gown is wearing lead, including a collar lead to protect him. And this hat that he's wearing also has radiation protection under it as well. And we usually wear monitors to monitor the amount of radiation we're exposed to during the procedure. Where is the highest risk of exposure to the operator from radiation? It's not from the camera, it's actually from scatter. So when the radiation source from below sends radiation X-ray up to the patient, and then when it hits the patient, there's a lot of scatter to the side. So the patient is actually where the source of radiation is. So you want to make sure you cover that and as much as possible to reduce your scatter exposure. I think that's at 40 minutes there. So to summarize, coronary angiography is a major component in the practice of cardiology. You can't be a cardiologist if you do not know when to refer a patient for an angiogram and how to interpret the results. Not every cardiologist needs to be able to do or has to do a diagnostic angiography or PCI, but they have to, have during their training done a few rotations so they understand what it is. It's an invasive procedure with a very low but real risk of major complications. And operators should learn and practice safe techniques to minimize procedural complications and radiation exposure. So, so now that you know how the procedure is done, why you're doing it, and why and what the risks are, you can obtain consent from the patient, explain to them the procedure and what the risks they are taking by proceeding. I'll leave this up for now, but I'll open up to questions and discussions and any comments.
بارك الله فيك باسم، محاضرة ممتازة جدا، وزي ما قلت basic very simple لكن معلومات مهمة جدا. يعني بنفتح المجال للإكسبرت بانل لو عندهم أي تعليق، بعدين ناخذه في أسئلة ممتازة من الحضور في الشات بوكس نوصلها لكم واحد واحد. دكتور محمد العيان interventional cardiologist. دكتور محمد لو عندك أي تعقيب إضافة على النقاط المهمة اللي قالها الدكتور باسم، تفضل.
السلام عليكم، شو الأخبار؟ محاضرة قيم، بارك الله فيك. ما عنديش تعقيب، يعني عم أعتقد إنه هو الدكتور باسم he covered most of the most important things يعني في الكات يعني. طبعا هي المحاضرة قصيرة، يعني ممكن لو كان في وقت أطول، لو كان واحد يقدر go in details يعني about, for example, history, يعني كيف how you take the history and then how you do the physical exam, what are the points which you can focus on in the history يعني before the CAT. لكن إن شاء الله في المستقبل ممكن يعني لو فتحتنا الفرصة يعني ممكن نتكلموا more details. يعني أنا أعتقد إن هي المحاضرة كانت ممتازة جدا و covered the most important things يعني. فلو تبيني ناخذ يعني الأسئلة اللي مطروحة يعني.
خلاص نقدر نبدأ بالأسئلة. غير أنا عندك سؤال دكتور باسم علق على موضوع الاكسس. يعني حاليا يعني اغلبيه السنترز والجايد لاينز ريكومنديشن ستاندرد براكتس تو يوز راديال most of the cases لانه less risk of bleeding. فمش عارف انت in your own practice نفس الشيء save الفيمورال المور complex procedure more support. ويعني حتى دي نقطه تعلق عليها.
يعني
ايه محمد بالنسبه ليك انت زي باسم قال
اغلبيه الحالات ممكن حتى في الباي باس سيرجري في الكابج يعني مرات نمشي الليفت ديستال راديال يعني في معظم الاحيان يعني حتى في الكابج يعني patients. لكن في I agree with him يعني sometimes يعني it's much easier to go from femoral to get the grafts, especially if you don't know the anatomy, you know, if you don't have pictures before, if you don't have the report. بس لو تمشي left radial يعني هي مشكلة الليفت راديال مشكلتها لو واحد مثلا قصير شوية يعني it can hurt the back. يعني لما تمشي distal left radial يعني ممكن تجيب يعني الارم يعني على across the table وتبدا يعني ممكن minimize يعني مشكلة انك انت تبي تطبس هيك واحد يعني مش تدير البروسيجر يعني. فما نعرفش هل هو
وهي باسم على النقطة هذه. طب انت عارف على الكومفورت ليفل يعني بالنسبة للكابج بيشنت بوست كابج you can use الليفت راديال ولا الفيمورال؟ مش عارف تعقيبك عليها النقطة هذه اللي
اي طبعا زي ما قال محمد if you go left radial you can get to the lima. إذا مشكلة left radial is not comfortable for the operator. بس المشكلة الثانية الأكثر إن if you have a short patient with a short ascending aorta, engaging the grafts can be really challenging, especially if you do not know where they're coming from. يعني الجراحين متاعين ما يحطوش في مركز على الجرافتس. A lot of operators, if someone's really obese where the risk of vascular complications from femoral axis is high, I would still go left radial. But we still need to be competent in doing femoral access. And we need to train future fellows on femoral access. So I think this is one caveat where, okay, let's just do femoral to make sure we maintain those skills and we can learn them. And also, I've had patients where I've gone left radial and I had to switch femoral because I couldn't find one or two of the vein grafts. So that's my approach. But it's not the الأغلبية. A lot of people have practiced. I know that with left radial for graft cases.
بس في معنا الدكتور عادل ديوب cardiac surgeon.
السلام عليكم.
وعليكم السلام.
السلام عليكم. Sorry, شباب. I just finished operating, so I was listening to the lecture while I was dictating. It was nice. Basem was really good. It was a great presentation as usual. Yes, it's basic, but for me, I think I learned a few things. From the practical point of view, I hear access, I mean here predominantly over 90% is you rarely see the femoral. So the question number one is, does the use of the ultrasound guided, that we see it now with TAVI, with my minimum invasive when I do perclose and percutaneous cannulation, it seems to be the ultrasound guiding puncture has become much safer, I think, even for the femoral access. Before, I think, was pretty much blind. You just go with the fluoro and you see with the femoral head. And a lot of cases when we see a lot of high bifurcation, common profunda comes up. And I mean, if these are like CT images, but I think one thing is for redo, for the graft, is it easier for radial approach to get the lima shot all the time or not? I have personally one of my favorite interventionists. In every CAT case, he shoots the mammary for us, which is I would really love to see two things from the cardiology point of view: a nice cine picture for the ascending aorta to see if there's any calcification. I always tell my resident that calcified aortas and non-usable mammary should not be a surprise, because you can't spend half an hour, 20 minutes harvesting mammary and it's not usable because there's no flow in it. And I think if the cardiologist can spend an extra 2 minutes to just do a cine to the ascending aorta, you don't have to do a root angiogram, but just a quick, just go a little bit up to see the distal aorta, mid-ascending aorta, to look if there is any, I call it the line of death, if there is any calcified shells, because we've had so many surprises of my colleague when they called and they want to off pump and no touch techniques and do lima remas, and So by doing this, I think you do us a favor. So lima shot and the ascending aorta. The other thing I'm going to comment with regard to the axis is because I'm now almost 20 years, including my training. At the beginning of my training, we used to do a lot of radial grafts because people want more arterial conduit. And then for some reason, there has been changes and hesitancy. So and we start seeing cardiologists doing more and more radial access. So what happened is the radial graft, we could take the radial graft from the left, non-dominant hand, and the anesthesia will use the right radial for arterial monitoring, which has already been used for radial access. So I think we've seen some complication from very rare complications, but also it's forcing us to sometimes the arterial line is not usable because either there's a thrombus or whatever. So we have to go either to the brachial, or a lot of the time because the other left hand is being used for grafting, we have to be forced to have femoral as an arterial monitoring. So, and that had created a little bit of issue with ICU monitoring. You cannot ambulate the patient because you have to keep the art line for a day or two, blah, blah, blah. So it's good for you guys, but sometimes it's not good for us. But these are just two things, but I think depend on radial for sure is very good for patient, quick turnover, less complication. We've seen a lot of those big bruises and big hematomas in the femoral, which is really ugly when it happens, causing vascular, retroperitoneal bleed and all that stuff. So, but these become very extremely rare with the guidance, the ultrasound guiding puncture and stuff. So, one thing, Basem, I think you have to educate all of us about those wires that you guys use and all these J4, J5, J6, J11. I hate it when I go to do TAVI. I feel like I'm dumb. So we need to probably spend some time in the future to educate us about all those wires.
Okay, Adel, thank you very much. يعني as usual, very good comment. باسم لقيت لو تعلقنا على اللي اتكلم عليها دكتور عادل بالذات الكيسز when you find severe vessel disease or a left main.
Yeah.
Regarding shooting the lima or ascending aorta, what's your comment on that? Like as standard of care, practice, it depends. يعني لو تعلق عليها وبعدين نسمع من محمد وعبد الغني.
ما شاء الله طبعا هذا روز a few points there يعني في السؤال بتاع أول حاجة بتاع لو a patient you're going to send for cabbage, the ascending aortic calcification من غير ما حتى تدير فلور سيني to it, you can see it. يعني لما نديره في البروسيجر I can see that there's a lot of calcium. So I usually would and it doesn't take 2 minutes, it takes 1 second. Just have an AP angle and a quick cine and you can see the ascending aorta and you can show the calcification. And most of our surgeons will get a CT anyways, but I think that is very helpful. Unfortunately, shooting the lima is not straightforward because we're going right radial. To get to the lima, you'd have to go down the right radial, transverse aorta, up to the subclavian artery to get to the lima. So that's very challenging and might include doing non-selective shots. So I don't think that can help you there. If you're femorally, yes, but not sure if we can do that if we're right radial. He also mentioned the use of ultrasound. So I didn't cover, I was worried that might be too much, how to be safe in femoral access. Because remember, I showed you that you need to hit that marker between the below the external iliac artery, but above the bifurcation. So there's a few ways to do that. I use skin landmarks to try and identify the iliac ligament. You can do fluoroscopy. I usually go in with the microcatheter for French sheath first to make sure my puncture is good before committing to the bigger 6 or 7 French sheath. Use of ultrasound is gaining a lot of traction now because you can see exactly where the bifurcation is, and you can also avoid anterior calcification. So if you got a spot that's calcified, try and hit it just above or below that spot. So those are all safety measures to try and get good femoral access. Unfortunately, the radial access can occlude when you go radial, and we see that. We give heparin in all the cases where we go radially to reduce the risk of radial artery occlusion. It happens about 5 to 10% of cases. So that's part of the risk with the procedure where you lose the radial. I'm going to ask Adel one more question. Do you put the wire markers for the grafts when you insert them? And if not, why? Because those can be very helpful.
We are the pioneers of this approach. Like I think in Hamilton, we are the only center. I think I've asked so many people, I don't know why, since day one I'm here. it was a must. You have to put graft markers on all the patients. We've seen people from Toronto. I was in the adult congenital. When I asked this question, everybody was looking at me. Nobody does it in Ottawa. Nobody does it elsewhere. So it seems to be something peculiar to us, but it's 99% our patients have a graft marker for the ease of access for subsequent graft marking for graft angiogram. So yes, well, I don't know if you practice there, but does your people leave you in the limbo to go on fishing expedition?
No, it's basically a fishing expedition.
عندي سؤال مش عارف يا باسم يعني تدير فيها الطريقة هذه ولا لا يعني sometimes I use CT scan يعني before the procedure يعني لو patient عنده مثلا high creatinine ولا هيك والجرافت مثلا old وما نعرفش الاناتومي فI use the CT scan before. and it's very helpful يعني مرات يعني خلاص تعرف ان الجرافتس مثلا they are occluded مثلا 1 or 2 you are not going to fish for them so you avoid يعني giving high volume of contrast. I don't know what's your approach يعني.
That makes sense.
Basem, I would highly recommend just meet with your group. It takes, as you said, 2 seconds to get an extra image for us. It takes 1 minute. It could be done by the most junior BGY. When you actually let the trainee to do this, they will be very excited. Just go around them. You know, it's the stuff that you pull from the sponges, the radio-bake marker. That's what we put. It's like a teardrop. You just go, small red clip. That's it. It does not subject the patient to any risk. It's in the ascending aorta in front of your face. After you decannulate, after you reverse the heparin, it takes 2 minutes. 2 minutes from, I mean 1 minute probably.
معلش good point. في دكتور إبراهيم زبيدة كارديك سيرجن يعني استاذنا معنا حتى هو مش عارف دكتور إبراهيم لو تيجي تفتح المايك وتعلق على النقطة هذه بتاع الكابج putting a marker لو تيجي تسمع فينا.
السلام عليكم ورحمة الله وبركاته. شكرا لكم جميعا على النشاطات الأخيرة هذه في المدة الأخيرة بصراحة غير عادية. أنا معي الجينور متاعي في تاجورة وحتيتهم أن يحضروا المحاضرات هذه بالذات والمحاضرة هذه بالذات لسبب واحد لأني شفت في أبيوز كبير في البري أوب في الفالف سيرجري للكوروني أنجيو. طبعا الجايد لاين فيها واضح ومعروف وممكن تسمعوها من الدكتور باسم. النقطة الثانية اللي الماركر ما نحطش في الماركر أصلا في الحقيقة يعني وفعلا متعبة ممكن للناس اللي يديروا في الأنجيو. للأسف ما نحطش المارك. عندي صديقي خالد السويني كان في كندا ويحط في المارك تقريبا أعتقد باستمرار ونشوف هذه حاجة كويسة جدا. يعني أنا ما نديرش فيها شخصيا بل أنا عندي مشكلة أخرى أصلا أنني الميموري ندير فيه هارفاستنج وداوت حتى كليب ما نحطش فيه مرات أصلا. معناها ممكن ندير صورة ما تشوفش إن فيه ميموري يعني في كليب على الميموري أصلا. النقطة الأخرى الإيفالويشن أوف بوست كابج الجرافت أعتقد most of the people ولا recommendation أنا أحسن بالسي تي أنجيو. بس شكرا لكم جميعا.
بارك الله فيك دكتور إبراهيم مشكور. باش نمشوا لنا في أسئلة جدا ممتازة وما نبوش نضيع الوقت. باسم وفي دكتور عبد الغني الساعدي لو حد منكم يعلق على موضوع الروتين كورونري انجيوجرام before الفالف سيرجري. روتين كورونري انجيوجرام الانديكيشن بتاعها يعني ودكتور إبراهيم علق إن في يعني اوفر يوز الكيسات اللي هو going for valve surgery. يعني for example someone young, let's say someone in their 40s, female mitral valve prolapse, we're going for surgery and she gets heart cath. فمش عارف تعليقكم على النقطة هذه بالنسبة ل indication wise. عبد الغني الساعدي interventional cardiologist في تفضل عبد الغني.
ايوه السلام عليكم. تسمع فيي ايمن؟
كويس نسمع فيك كويس تفضل.
تسمع فيي ايمن؟
عبد الغني نسمع فيك كويس.
تمام. بالنسبه للبري هدايا انجيوجرامز موضوع مهم جدا. حتى هنا ما فيش عليه كونسنسس صراحه. في امريكا معظم الناس اللي يمشوا لفالف سيرجري they go معظم الناس اللي تمشي لفالف سيرجري they get invasive angiograms first لانه هو very بسيط ويعني quick و less contrast. يعني you could يعني do a quick coronary angiogram ممكن like 40 cc's of contrast as opposed to like 100 or 120. المشكله اللي عندنا هنا في امريكا ان a lot of times the insurance companies do not approve it. يعني عندنا ناس صغار هلبة و they would يعني you could almost swear ان هم ما عندهمش اي اي angiographic abnormalities.
عبد الغني صوتك يقطع، حتى الانترنت تعبانه في امريكا.
ممكن
ولا واخذ شيء بلان. عبد الغني
can I comment on this شباب شوي؟
Yes, I will comment too. I have a comment too after عبد الغني finish.
طبعا غير بقول حاجه، بما انني الوحيد اللي فيكم جنرال، لحظه بس، الوحيد اللي نون انفيسيف يعني nowadays ال coronary CTA it's a good tool in such a patient when you have a low risk. تفضل يا عادل، بعدين ناخذ محمد عيان. عادل تكلم انت، بعدين ناخذ محمد عيان. محمد ما نسمعوش فيك. عادل تفضل.
ماشي، لكن تبي نتكلم نقدر نتكلم يعني.
عادل كيف بتكلم، بعدين بعدك محمد. خلاص شكله عادل ما فيش حيتكلم. تفضل محمد، يعلق على النقطه هذه.
في جايد لاين على before valvular heart disease replacement يعني not shelled. يعني لو المريض يعني الايج، يعني هذا الكت اوف بوينت هو 40 years. لو above 40 years يعني there's recommendation انك تدير coronary angiogram. below 40 years لازم يبدا عندك 2 other risk factors، يعني مثلا diabetes, hypertension, smokers. وبعدين يعني هذا يعني الجايد لاينز يعني ان بريف يعني في امريكا
في هذه دوكيمنت ستيتمنت في الامريكان كولج اوف كارديولوجي على الهارت ديزيز. صحيح،
في دوكيمنت ستيتمنتس يعني في الايج اللي هو 40 years. لابوف 40 years يعني في ريكومنديشن انك تديرها.
محمد من ناخذ باسم، يا ريت لو انت السلايد هذه تحطها لنا على الجروب نتاع الفايبر ولا الفيسبوك، يا تكون مشكور جدا لو فيها امكانيه. بعدين
نشوفها ونحطها يعني في جايد لاين.
باسم تعليق على النقطه هذه، ان في هلبة اسئله لو بنسالها من على الشات باكس، ما نبوش نعطلوا هلبة في النقاش على مواضيع ثانيه على الموضوع هذا.
الجراح يحول الحاله يبي diagnostic angiogram before surgery. I just do it. يعني ما عنديش big opinion. It's really يمكن عادل طيب يمكن عنده better insight than I do.
ايوه عفوا شباب، انا معلش صار لي شكل disconnect. Can I comment or somebody is talking because I think I get.
تفضل يا عادل، تفضل يا عادل.
Okay, so with regard to the angiogram in valvular cases, I think there has been a change in the last 10 years, especially with the advent of TAVI and the advantage of the CTs. So even if you look at the TAVI, I think it depends on two things. The disease process that you're dealing with, like if I'm dealing with an aortic stenosis, is different than if I'm dealing a mitral valve. Like I'm telling you, I could actually bet money on somebody with P2 prolapse, myxomatous mitral valve, 46 or 52 years old. I can tell you $1,000 he's not going to have coronary disease, and he's going to have a clean peripheral, and I can cannulate his groin vessels with no atherosclerosis. But if I have a 70 years old severe aortic stenosis, even if he has no angina, asymptomatic, I'll tell you, there's no way I'm operating on him without an angiogram. I think here in the North American Western society, I think we're covering the medical legal aspect. Even if it is 1% chance that you may open and find 70% LAD or 60% diagonal, and if something happened to the patient, oh, you didn't bypass that. Why he's ischemic? Why he's having ST changes? Why he's crashing in the ICU? So I think disease processes is important. What is the diagnosis? If I'm doing a drug using the carditis 26 years old, I'm not going to ask for angiogram. Why? Depend on the age. That's number one. Second is the disease process. And I think the coronary CTs are getting much better. I am not sure that we are in a position, maybe in a few years from now, we're going to be talking about just ignore the angio. Is it about time to say, okay, I can operate on somebody based on what the cardiac CT tells me from the coronary blockers? Is it 50, 70, is it 60? They're very accurate, I'll tell you. They're very good. A lot of the TAVI patients that we see, when we look at their CT, the TAVI team, the interventionist tells me, Adele, this guy has no coronaries. Sometimes we make that assumption. We don't go and do an angio. And what happens is when we bring the patient to TAVI, because we do it as a team, they just go and do a quick shot, but they don't do it in planning. They do it intra while we're doing the TAVI. So there's nothing 100%. I think there is.
هو عادل سمحني نقاط. هو شوف I think انت summarized very nicely على كلام محمد. There is a document statement for general guidance. what you said انت على البري تيست probability المريض اللي عنده aortic stenosis in their 60s 70s more likely to have coronary disease compared to the young gal in her 40s with mitral valve. النقطة اللي علق عليها باسم إن it's a consensus interventional cardiologist والsurgeon يعني what's their understanding for the best for the patient. فيعني it's not like black and white. It's every patient is different. في نقطة قلت عليها أنت وعلقت عليها بقى شوية الcoronary CTA it's a very good يعني option diagnostic non-invasive. زي ما شفنا الحالة اللي ورناها الدكتور باسم من بكري نداله diagnostic كات المريض خش في dissection. It happened يعني هذه part of the procedure. The field it's invasive procedure complication can happen.
Ivan, if you let me just comment one more thing, just I'm gonna shut off after. Is the benefit of coronary CT, what I see it, like sometimes the angiogram does not provide. I do a lot of minimally invasive CABG, lima to the LAD by a small left mini thoracotomy. A lot of the time they give you the angio and they tell you, I think, yes, I think it is intramuscular. So I need, for me to do this, I do it beating heart. So I need to make sure that the vessel is not intramuscular. So the best thing for this, after angiogram, I ask for coronary CT. And a coronary CT, when I review it, it tells you how deep it is, which segment is epicardial, which segment is intramuscular, and where it is in relation to the intercostal space. So as I said, I'm a big believer of individualized care. A lot of people follow guidelines, but I like the flexibility in the recommendation.
ممتاز.
Ruling out intramuscular vessels is very helpful when you do a beating heart.
ممتاز. Well, I give you anatomy coronary CTA. It's non-invasive heart cath. Very good point. Thank you so much. باسم قلت لك هل بأسئلة على السريع يا ريت باختصار وحندخل معنا الاكسبرت مان في الإجابة. في الأسئلة في دكتور سامة قال بالنسبة للألنر والبريكيال أكسس what's the precaution؟
بالنسبه للبريكيال اكسس هذه last option. يعني عندك المريض is missing both legs with radius. You we see that in dialysis patients a lot. Last option, brachial access. The risk of bleeding, you don't have good option to compress or control the bleeding. There's no devices, you'll have to hold, and the risk of bleeding. Ulnar seems to be generally safe. If you can't get the radial access, you can switch over to ulnar. It seems to be generally safe, even though it's a bit closer to more of the nerves towards the hand. But yeah, I've used it a few times, and then the TR band, you just put it upside down and it works fine. So you can use ulnar as well. I don't have any major issues or risks.
I think محمد العيان في دكتور نفسه أسامة تكرر بالنسبة للمرضى اللي عندهم bronchial asthma. Do you recommend giving steroids?
Just the general recommendation يعني البيشنت مثلا wheezing وهيك يعني ولا لو اني فكرت اني ممكن استخدم ادينوسين يعني otherwise I don't use it. No.
بالنسبة ليك باسم شكرا.
يعني أزمة ما عنديش أي استخدام ليه. الحاجة اللي ما ذكرناهاش اللي ما ذكرتهاش one of the risks which is rare is anaphylaxis reactions to the dye. That we see that from time to time. So is there any history of previous reactions to CTEs, the same dye, so CT, etc. If they have any previous reaction, then you'd have to pre-treat them, including steroids and antihistamines. But other than that, not really, no.
نقطة مهمة جدا. في سؤال على الرول اوف سيديشن بيفور الهارت كات يعني البنزودايازيبين والفنترين شنو بالنسبة ستاندرد اوف كير اتليست في اليو اس ستاندرد اوف كير.
Yeah, same thing. One of Versed 50 of fentanyl to start, give more until the patient is relaxed. واحد من my colleagues comments heaven is when the patient is snoring and the oxygen saturation is 91%. So they're relaxed, but they're not hypoxic. Okay. So I always give a dose of nitro for the left system to rule out spasm. I don't do it for the RCA routinely, but if there's any concern that there's spasm, we give some nitro. So that's part of the procedure as well. Agreed.
ما شاء الله عليك يا بس لأنه هذا كان next سؤال الرول of nitrate. محمد العيان.
The same. So I give in the left system. I give some nitro. For the right, and I see spasm. I don't give. But it's very important يعني if you suspect spasm or even when you see a lesion, it's very important to give some intracoronary nitro to be sure.
أنا ممكن عبد الغني فقدنا لك رجعنا نسأله. سؤال ثاني يعني بالنسبة للكوكتيل الراديال كوكتيل بعد ما أنت تأخذ الراديال أكسس عشان ضابط يصير سبازم في كوكتيل ينعطى شوية هيبارين عليه فيراباميل عليه نيتريت. الثاني كم الدوز بتاع الفيراباميل على السؤال، الدوز بتاع الكالسيوم شانل بلوكر هاو ماتش وشنو يعني البريكوشن. مش عارف محمد، بعدين اسال باسم عليه.
في العاده احنا نفس الشيء يعني نعطوا في شو اسمه يعني في اتليست يعني في نبراسكا هارت يعني نعطوا في كوكتيل يعني نيترو وفيراباميل وهيبرين. يعني في some operators ما يعطوش في هيبرين نين دي كروس الارش يعني بس لو انك انت ما قدرتش تدير كروس للارش ممكن تمشي فيمورال سيفر. وفي some operators يعطوا مثلا 2500 يعني before they cross the arch, after you cross the arch you give another 2500.
شكرا محمد. كمل اسمح.
فما نعرفش يعني باسم كيف ايش ندير يعني في العاده نعطي في 5000 يعني في تو نيو يعني serious يعني يقولوا انه هو الريسك بتاعنا if you switch to femoral there's no big issue يعني حتى if you give 5000 I use the ultrasound 100% of the time يعني for the femoral axis يعني.
Yeah, so أنا نستخدم في الverapamil 2 milligrams intra-arterial for spasm, and if there's still more spasm, I'll give nitro on top of that. Verapamil burns, alkalotic, so you mix it up with blood to try and buffer that feeling. Heparin burns as well, so I usually give the heparin once I've crossed the arch. The concern is that if you have to switch to femoral, then you don't want to have that heparin on board. But it's not a major thing, and then so that's the usual cocktails. You want to prevent spasm, and you give the heparin to prevent or reduce the risk of radial artery occlusion.
Just to summarize this question, أنا المريض لما يجي للكات لاب بعد الانديكيشن كانت appropriate, the patient explain the procedure, get the access, يكون تعطيه الsedation والpain medication so he's comfortable. Once you get your radial axis, you give this cocktail, a combination of heparin, verapamil, and nitrate. That's the standard of practice, correct?
It varies from place to place, but yeah, generally, yes.
General. بالضبط. السؤال في يسأل الدكتور أسامة كاتب هل يستخدموا في الدايمتر بتاع الأورتا على الإيكو باش يساعدك في selecting السايز بتاع الجيل كاتيترز؟
محمد.
Yes, يعني في العادة نمشي لنشوف في الإيكو ونشوف يعني لو إن كاتبين يعني قديش السايز بتاع الأورطة ولا نشوف لو عند البيشنت CT scan sometimes it helps.
بالضبط. يعني لو المريض ما عندهاش aortic ascending aortic aneurysm I think الكل start with standard GL4 صح؟
we'll start with the standard. For me I usually go with the tiger. يعني when I go radial يعني I use the tiger because you can engage both right and left at the same time. And you don't need to exchange it. It saves some time. يعني فما نعرفش
يعني أنت you use different catheter يعني more
يعني one catheter for the right and the left. هم الدوز وحدات اللي هم اليونيفرسال اللي هم التايجر والجاكي. يعني في العادة نستخدم في التايجر يعني نمشي للرايت والليفت
use one catheter. هو غير الناس اللي مش فاميليار بالموضوع هذا اللي اتكلم عليهم الدكتور باسم في المحاضره جي كاتيتر جي ال والجي ار هذا من ستاندرد جينكنز كاتيتر ان واحده للرايت وواحده للليفت. في نيور كاتيتر اللي اتكلم عليها تو الدكتور محمد اللي هي التايجر انه the same catheter you can engage to the left coronary artery and right coronary artery. باسم على النقطه هذه من ناحيه الاسنيه ورثه نفس الشيء ستاندرد اوف كير جي ال 4 صح؟
For radial GL3.5, and then because it's an S shape, it moves it forward. But femoral GL4. But if if the patient's got an ascending aneurysm, you don't need to, it's large. Then it doesn't make sense to go with a smaller catheter. Then you need to go big. But other than that, yeah, that's usual standard starting. And if it's not going to work, it's going to be clear early on that it's either too small or too big. Then you have to exchange.
السؤال شكرا سؤال مهم جدا من الدكتور رجب. شنو الهايست فاليو بتاع اليوريا والكرياتينين ما تديرش عليه كات؟
ما فيش. If the patient needs the cath, they got the cath. They just have to understand the risk. There's no contraindication. But you have to be absolutely careful. If واحد يعني عنده atypical chest pain ومديروا له stress test و referred for cath والكرياتين بتاعه 400 يعني خلاص pre-dialysis لا. لكن لو يحتاج diagnostic angiogram renal failure, renal impairment is a big risk factor for coronary artery disease. So if there's a good, clear clinical indication, you do it, you use the least amount necessary. You can do a diagnostic angiogram with 10 to 15 cc's of contrast.
باسم will send I agree with you بس محمد غير بقول لك حاجه تعليقا بس من general cardiology بس ان case by case individualized I tell my patient people die from their heart not from their kidneys. يعني لما يجيك مريض with STEMI okay you don't care about their creatinine. يعني we do heart cath for patient even on dialysis. فهي مش معناها don't care about the kidneys. What's your indication? يعني what's the real indication for this patient? If there's a strong indication for it, you go ahead, you fix the heart, then you can deal with the kidneys later. محمد شنو تعليقك على النقطة هذه؟
تعليقي أول حاجة يعني تشوف هل هي مثلا urgent can you delay it يعني ممكن تدير preparation يعني تعطي البيشنت rehydration هو the most important thing يعني recommendation from 3 to 6 hours before the procedure وتعطي يعني almost 12 hours after the procedure يعني IV fluid يعني
بالضبط يعني انك البوينت بتاع ان optimize الكدني function as much as you can if you have the leverage of time if there is no urgency.
Exactly. وعندك يعني عندنا فورمولا يعني ممكن نسأله سؤال يعني الفورمولا هي تضرب 5 في الويت بتاع البيشنت بالكيلو وتقسمها على الكرياتين ليفل. هذا المفروض يكون الماكسيمم الكونتراست فوليوم والتارجت بتاعك المفروض تكون half of this
خلاص
or less يعني.
الحين نتكلم عن الكونتراست. في سؤال شكرا محمد. في سؤال من دكتور محمد هل في scoring system assessing الكونتراست induced nephropathy especially for patient اللي هو multiple comorbidity وعندهم مثلا low EF يعني انت
في يعني كم scoring system and most commonly used is the Mehran scoring system with Dr. Roxana Mehran. And most of them seem to overestimate the severity of contrast-induced nephropathy. So, استخدمت هيعطيكوا dialysis of 10%. I think we're overestimated, but there are scoring systems that you can use. I usually, tell the, off-label, I'll tell the patient to risk by half of that score.
طيب ممتاز. الماكسيمم محمد عيان الماكسيمم amount of contrast. طبعا I think البوينت من عادة interventional cardiology they try to minimize as much as they can.
زي ما قلت لك اللي هي تضرب اللي هو عندنا فورمولا اللي تضرب 5 في البيشنت ويت بالكيلوز and divided by creatinine هذه الماكسيمم but التارجت بتاعنا المفروض تكون 50% of that maximum. المفروض تعطي البيشنت less than 50% of that maximum يعني.
So احنا عندنا في الكات لاب بتاعنا التكنيشن will write the maximum recommended contrast dose on the board so we can all see it. Okay, so if you have done a diagnostic angiogram and you're almost there and the patient needs PCI, maybe stop and stage it. Best, if you're in the middle of the procedure and you need to see what you're doing, Allah غالبا you have to take that risk. But that's the balance.
وزي ما قال باسم يعني في مثلا طرق جديدة يعني ممكن تقدر تستخدم يعني زيرو كونتراست يعني درناها قديش مرة يعني لو عندك مثلا OCT ولا هيك وعندك كو ريجستريشن يعني تضبط الواحد الليجن وين بالضبط وتقدر يعني تدير شنو اسمه يعني without يعني ممكن 5 cc or less يعني at the end of the procedure يعني باش تتأكد بس فتقدر انت تدير اوبتمايزيشن للستنت وتقدر تحط الستنت يعني without giving any contrast يعني لو ان الريسك very high.
باي ممتاز. طبعا في سؤال من احد الدكتورات واي الهايبركاليميا كونترا انديكيشن بيفور الهارت كات يعني لو انا اخذت السؤال صح على النقطه هذه على الهايبركاليميا
هو المين ريزن انك انت تمشي بتدير كات يعني انت بتخلق some sort of ischemia ويعني ممكن تزيد الهايبو ولا الهايبركاليم ممكن تزيدك ريسك اوف arrhythmias يعني انت ما تكونش عندك اني electrolyte disturbance يعني before you go for the hard cat يعني I'll see what
في مرات مش عارف تعقيب باسم وفي مرات اصلا المريض اللي عنده هايبركاليميا يعطيك اس سيجمنت elevation looks like STEMI
another thing يعني هو اصلا هايبركاليميا في العاده sick patient يعني why is hyperkalemic يعني اكيد في حاجه يعني you wanted to stabilize the patient before you go for the cat.
انا معلش عندي سؤال نسوق يا شباب ما نقدرش نكتب لكن ما قدرتش فمعلش يا سؤال انا المهم لباسم when you contemplating doing angiogram a sequence of doing things you show us earlier a case where you've had a diagnosis of type A dissection.
Yeah.
Is there any way that you when you start doing like is it the LV angiogram first, is it the right main first, left main first, is it a root shot, is it So which one before you, is it if you have a post-MI VSD, sometimes you don't have, you know, is there any way or any sequence you follow? Is it standard? Is it tailored to the patient's presentation?
Yeah, so my standard is to start with the left, then go with the right, and then plus minus LV angiogram if it's planned. So that's the standard approach for when I'm doing a diagnostic angiogram. Some people will go with the right first, especially if they're going radial. That's my usual standard. If there is suspicion for something else going on, then it's tailored. So I had a patient who presents with an inferior MI, 3 days of chest pain. He shows up to the cath lab in frank pulmonary edema. This makes me worry that there is a mechanical complication. I want to know that right away. So then I'll start with an LV angiogram. This patient that had a Stemi with inferior that the operator could engage the RCA, now he starts thinking, is there something else going on? About 1% of type A dissections are diagnosed for the angiogram. So that's the usual approach, left, right, LV, plus minus LV. That's my approach. And even the pictures, I go in a certain sequence or angles and add to them as needed. But you know, if there's a certain presentation that requires something different, then I would change for sure.
And Basem, not infrequently that people have a diagnosis of type A dissection and they're like 60s. I think for me, we don't waste time doing angiogram because very few people would accept to do angiogram in a type A dissection.
I completely agree. I mean, the risk is by the hour.
خاصة السب-acute أو الكرونيك اللي acute مرات when you have to save the patient, you think of the 10-hour survival, not the 10-year survival. لكن مرات missed وبعدين يقول لك I don't feel مش عارف ايه can you يعني very few people can do angiogram with a type A dissection.
If you need it, I will do it. That's my approach.
You do it a femoral or radial approach?
Depending on where the dissection is. I look at the CT. If there's images down to the femoral, then I would decide. But you know, this is one of the conditions where I probably will go femoral, especially if I know that the femoral is true lumen.
لكن نقطة معلش باسم وعاد في الكيسز هذوك يعني الكارديك سي تي اي تكلمنا عليه كوروناري سي تي اي يساعدك حتى في لوكلايزنج الدايسكشن قلة الاوتلت والاناتومي. طبعا هو انت عارف يعني لما تاخذ الايورتا ديفن الكارديك المهم لان وقت ما عاش عندنا هلبة محاضرة ممتازة جدا جدا في شوية أسئلة ما لهاش علاقة هلبة بالتوبك تكلمت عليه أنت بس لكن أسلوبكم على السريع في دكتور كاتب what's the ECG changes and the area supplied by a ramus intermedius أوكي يعني مش عارف أن حد بيعلق على النقطة هذه وفي بعدها سؤال ملغوم نسله لكم فوتوا روحكم.
ملغوم لا فكنا
لا الملغوم سؤال كويس جدا أنا عارف السؤال شفته بكري سؤال ممتاز جدا.
خلاص بجاوبني على السؤال الاول انت ولا محمد بالنسبه لل الاي سي جي تشينجز والاريا سبلاي باي ذا ريمس انترميديس هل حتحطها في المحاضره الجايه بس؟
لا هذه طبعا مش لانه مش لازم المحاضره الجايه بس هتكون lateral. Ramus usually covers the same territory as either the large diagonal or an obtuse marginal. So usually it's a lateral as T changes. So the ramus is basically an OM coming off of the left main.
Large OM.
It's gonna be either lateral which is the most common. والسكند يعني مرات تكون anterolateral يعني.
anterolateral بالضبط. السؤال الملغوم في دكتورة بشرى كاتبة why female doctor underrepresented في الكات لاب؟
I think that's a very good question. أنا قلت لك أنا سؤال كويس جدا ومهم. I think female physicians are underrepresented in cardiology in general, and even the ones that are in general cardiology, you know, cath lab or PC, the interventional cardiology field is underrepresented. يعني الجروب بتاعنا احنا في كندا and we are 8 interventional cardiologists. Currently we have 1 female interventional cardiologist. We had 2 at one point, but the other one moved. And I think that percentage or number is probably representative in most places. So those are the I think it's multifactorial why female physicians might have chosen other career choices or felt not welcome in the field. And I think that's to our loss. And هذا خسارة للpatients يعني if you have 50% of your physicians not represented, also any patients who come in they probably might feel more comfortable with female physicians, you know, if you're a female doctor. So the good news is that there seems to be a big push and a large, at least in North America, and even in the Gulf area for female interventional cardiology physicians. So they're becoming a bigger component and being more represented. You know, I've trained.
Can I comment on this, because my head of division of cardiac surgery used to be a female. The one who hires me in cardiac surgery, she was the first cardiac surgeon to become a chief of the division. Irene Sobolski, now she's retired. And the program director of our cardiology program, Alison Montgomery, was a woman. And we've had a female interventionalist. She's from Colombia. She did the fellowship here and she stayed. You know her, probably, Basem. Natalia Penela. Yeah. So I think there's a huge, I mean, not intervention. I think maybe the quality of life. Now the primary PCI become the standard of care, 24-hour. You know, could be a little bit, but I'm not sure if the quality of life and could be deferring people away. But I'm telling you, half of our cardiac surgery residents are females. واحدة من أبو ظبي. 3 Canadian.
ممتاز.
في مشكله بسيطه جدا اللي هي الحاجه الثانيه، يعني الراديشن. يعني معظم الفيميل يعني يخافوا من الراديشن، رغم ان هي معظم الاحيان حتكون سيف. يعني تقول لي ممكن she get pregnant and this. يعني سمعت قديش من واحده يعني كانت هذا الميجر فير بتاعهم، يعني الراديشن
بس النيرس is all female in the cath lab.
Yeah, but they are not exposed للواحد radiation يعني زي
دكاتره زي ما قلت لكم النقاش ممتاز جدا. اسئله في دكتوره حنان سالت سؤال والله عجبني جدا. كانت الحاله عندك في الكات لاب وخشت في فيزو فيجل وحطل. how you treat do you stop وبوستبون؟ محمد عيان ممكن تعليق على النقطه هذه؟
again I don't hear you well.
الدكتوره حنان قالت انت بتدير حاله هارد كات والمريض خش في فيزو فيجل during the procedure. how you do يعني you address الفيزوفيجل you treat them how you do it.
في الهارد كات يعني انت you're not gonna assume انه هو فيزوفيجل، يعني you will assume other things. يعني بتعتمد يعني على التشخيص بتاعك. يعني لما واحد يصير له هايبوتنشن يعني بتفكر انت بالضبط يعني شنو السبب، يعني لانك انت عاطي كونتراست تخاف انه هو انافيلاكسيس، ولو انك مثلا تدير في كات تخاف انه صار لك دايسكشن ولا صار لك اي شيء. يعني last thing يعني we'll think about it انه فيزوفيجل. يعني I will exclude the major things first، ويعني بعدين يعني نمشي الفيزوفيجل as a last يعني diagnosis. يعني
But very good point. Let's assume انك انت exclude والامور مجرد فيزوفيجل لو ما حطوا الاي في اكسس. هل you postpone the procedure do it another day ولا you carry on؟
I will carry on. يعني هو في العاده الفيزوفيجل يعني شويه وحيرجع يعني، وتعتمد عليه هل شنو اسمه الكيس اللي هي urgent انت نون ستيمي ولا ستيمي والبيشنت كراش ولا البيشنت ستيبل والكتف بروسيجر كان بي بوستبوند مثلا،
وتسهل حتى المريض كويس. زي ما قلت لكم يعني باسم متعلق على النقطه هذه بتضيف؟
لا ما عنديش مانع،
لاني حاب ناخذ دكتور عبد المنعم، هو كان المفروض يكون معنا في الاكسبرت بانل لكن جاته حاله انفيريور ستيمي فنجرح فيه تو خش، فبنخليه يختم على لو باسم متعلق على النقطه هذه.
لا ما عنديش تعليق يعني
باسم في نقطه انت تكلمت عليها بسرعه، موضوع لما تدير فيمورال والريتروبيتونيال بليد، لانك واحد كيف بادي وزي ما قلت بيمشي يحضر مع التورسان بهليل ومرات يبدا يكلموه على الحاله بعدين ما تطلع الكات لاب. يعني النقطه هذه شنو تقول عليها للدكاتره الجدد الجوني؟
ممتاز. So this could be an ASCII scenario. So عندك patient just post procedure كلموك he's hypotensive. شنو differentials؟ vagal تكلمنا عليه، allergic reaction يعني anaphylactic reaction. إذا كانت PCI بتشوف PCI complications, perforation, tamponade, dissection. Or big thing if it's ephemeral retroperitoneal bleed. So first things, try and sort out. You work your way through the differential diagnosis. Look at the groin if there's and press hard. While you're doing all this, press hard on the groin. Order blood products. Usually, the majority of retroperitoneal bleeds will tamponade themselves and stop conservatively. But it's not a bad idea to get the vascular surgeons involved early on and to discuss options.
Very well said. لا very well said. يعني
بنضيف نقطة بس. لو البيشنت ستيبل يعني بندير يعني طبعا الاجراءات اللي قالها اسمه باسم كل هذه، وممكن ممكن ندير مثلا كويك التراساوند وترفع البيشنت دير السي تي سكان يعني باش تتاكد من الدايجنوستس وكل شيء. البيشنت انستيبل في العاده يعني المفروض يعني يمشي back للواحد يعني. I'll take him back للواحد للكات لاب يعني. For me I can go and I will take picture from the other side and see what happened. يعني تبي مثلا ندير ستنت للفيمورال ولا whatever.
ممتاز. طبعا بقى محمد انت تتفق معي الديفرنشال اللي حطه بس ممتاز جدا وفيري براكتيكال. لو ان بي سي اي كومبليكيشن تفكر في البريشن والتمبونال ولا الدايسكشن.
يس
لو فيمورال تفكر في الريتنال بليد. طبعا ديما تفكر في الفيزو فيجل وال محمد رسول الله الالرجي الكونتراست مهم جدا جدا. والمريض مش تشوفه مره واحده وتمشي. You keep continuing to assess him every 2-3 hours. والبلد برودكت دي HNH وتتبع المريض هذا. طبعا الايكو مهم جدا بتساعد ايكو لكم فور فيوجن. وحتى لو لقيت نقطه مهمه مش عارف نبي باسم ومحمد يعلقوا عليها، لو حتى لقيت small effusion don't ignore it لان just might start early. البرفوريشن هذا مايكرو برفوريشن very small ف it takes time to يعني to accumulate. ف you have to take this seriously. صح باسم ومحمد على النقطه هذه نتاع
لأن لو fusion is happening that means that there's blood developing. or usually cardiac tamponade can happen with even small amounts of bleeding because the pericardium hasn't had time to expand and accommodate more space. So if you have a malignant effusion, usually there's huge effusion before the patient has tamponade. While in the cath lab, because it's an acute accumulation, you can have tamponade very early on. Also, you need to go back and look at the pictures to see if there was any perforation or a wire perforation that might have been missed originally.
يعني ما تخليش السمول افيوجن يعني مسليد تقول لا هذا مش هيخليه في هايبوتنشن. فهذه بوينت يعني محمد
very important. يعني new small infusion can cause tamponade very easily. يعني زي ما قالت البريشر يركب بسرعه والبيشنت تلقاه في tamponade. يعني زي ما قال لك يعني you need to go and review your images very quickly يعني وتشوف يعني مرات you missed something. يعني مرات انت تبدا مركز على حاجه معينه خاصه لما تدير في CTO وهيك يعني في الكرونيك توتال اكلوجن ولا الكومبلكس بروسيجرز. يعني مرات يعني تاخذك الواحد تبدا مش مركز زين فمرات يعني تشبح في بير فيك شويه فيعطيك انديكيشن ممكن ترد المريض للكات لاب وتدير مثلا ايمرجنت بالكارديوسنتيسز. ومرات يعني تضطر انك انت تدير
كجونيور فيزيشن في البال يتكلم السين وبتعرف تدنك. مشكور جدا محمد بارك الله فيك. فيري جود بوينت. باسم التيك هوم مسج بتاعك للجونيور اللي يحضروا محاضره اليوم انت شنو اهم حاجه تبين يطلعوا منها من المحاضره هذه؟ يمكن درت نايس جوب explaining the process in very simple way. البيج بيكتشر I think كان في great discussion وانبوت من الكارديك سيرجن معنا ودكتور محمد ودكتور عبد الغني. لو دكتور عبد المنعم تومي قاعد معنا شفته شويه يا ريت يعلق. لكن بس تقولي على الهم تيك هوم مسج قبل ما نختم ان شاء الله.
Yeah, take home message on coronary angiography is an important test to manage patients with cardiac disease, and it's generally safe and low risk, but they have to have proper patient selection and understand what the risks of complications are and know how to deal with them if they happen. And it's also any cardiologist will need to have seen and attended has spent some time in the cath lab regardless of their future career plans. يعني كل أي حد trained in cardiology يعني عنده rotations for the cath lab. It's very important to be able to understand what you're seeing. يعني you don't have to learn how to engage or take angles or pictures, but you need to understand what you're seeing and what the results can be and what the decisions after that are.
شكرا بارك الله فيك. ونقطة مهمة جدا هذه انك انت تمشي الكات لاب وتتفرج وتشوف ما تستعجلش تقول تبي تدير اكسس على طول. يعني it's not easy. يعني لو تشوف يعني الانترفنشنال كارديولوجيست it takes them 9 to 12 years to hold the catheter. ف you have to earn it, we have to watch it. ويعني it's a serious procedure و complication can happen. الكات lab is a stressful place. People take things seriously. ف don't rush things. It's important. فانك انت be there watching. It's a part of the learning process. مشكور جدا يا باسم. شكرا محمد لكل حضور. بارك الله فيك.
ايمن في حاجه نسيتها بقولها الباسم. لازم تقول ان التيك هوم مسج لازم يكون عندك صديق حميم كارديك سيرجن في السنه.
طبعا
لازم تكون
إعادة. وطبعا السبيد دايل مش يور وايف ولا يور سباوز، الكارديك سيرجن هذا السبيد دايل.
ايوه and vice versa when we screw up we have to call them back too.
يعني شوف انا
انستيزيا وكارديولوجيست على حبايبنا.
يا عادل هو شوف it's interesting you brought this point لان everyone should be comfortable asking for help. لو انت تقول interventional cardiologist type A personality save life put in stent balloon pump save life they do a great job الصراحة. أنا يعني I really amazed how much people can do in the cath lab. لكن still things can go south. They need backup from CT surgery, especially when you do a complex procedure. Or the same thing as CT surgery, they need a good cardiologist to help them identify the process. هذه good point. يعني الجونيور يعني حتى الناس السينيور no one's perfect. You always need help and support. We always ask for advice. يعني مش عيب. فمرة ثانية شكرا جزيلا باسم كالعادة ما شاء الله عليك محاضرة ممتازة جدا. أنا حضرت محاضرتك الأسبوع هذا اللي فات وهذا وإن شاء الله الدكاترة معنا حنستمروا في السيريس هذه مجموعة محاضرات كومبرهنسيف. حنبدأ من البيزك زي ما شفتوا اليوم. دكتور باسم إن شاء الله حيكون معنا الشهر الجاي يوم 24 جولاي السبت نفس التوقيت الساعة 8. حتكون على الكورونري اناتومي والانجيوغرافيك فيوز وحيكون معنا اكسبرت بانل جديد. بارك الله فيكم مشكورين وإن شاء الله نتلاقوا في السبت الثاني. السلام عليكم ورحمة الله.
بارك الله فيكم. السلام.
السلام عليكم. شكرا يا باسم وشكرا جميعا. بارك الله فيكم.
يلا بيضحك على المباراة.